Hello everyone and welcome to week 6. I'm going to begin with orientation and then I'll go into our lecture. So our goals for this week, or our learning objectives for the week, are to be sure that we have thoroughly understood concepts such as pay for performance, bundled payments and shared savings models, as well as accountable care organizations, the patient-centered medical homes, and clinical integration. We'll also go into some of the benefits of what we've seen among, I believe it was 32 accountable care organization pioneer programs, and then we'll look at implications of health reform on health services planning. And there's also a technique called the Delphi technique that I want to bring to your attention. What is it and how do we use it and how does it inform planning, and when can it be used? So those are our learning objectives. And so as far as the task for the week, of course, this lecture, there's a document called the Population Health Leaders Readers List that you need to read, and I've incorporated some of the language in the lecture. And there's 2 clips. One is on modeling the impact of healthcare reform, and the other clip is your orientation to the Delphi technique. All right, so let's get started. Oh, and there's no deliverable this week. No deliverable. I love this slide here because it is an overview, a very simplified overview of the Affordable Care Act of 2010, and it's been divided into 2 categories: insurance reform and health system reform. And so you can see here, with insurance reform, more people are going to be covered, there's more benefits and protections and lower costs within that space. The other around health system reform are efforts around quality and efficiency and workforce development and infrastructure. And the focus, which you hear me talk so much about because it's like my passion, public health and prevention. This is a great cheat sheet for you if someone asks you what is health reform and what does it mean and how does it, what are the different areas that it addresses. A great resource. And I pulled this from the APHA website. So if you want a really nice, clean version of it, you can access, I believe, this link here, because it may not be as clear because I just cut and pasted it into this slide. This is a little more descriptive. So for insurance, so it's pretty much in line with what we see here. You see the 1, 2, 3, 6 areas, and you see there's a description of all 6. And so you can see how Medicaid expansion, we're now looking at incomes under 133% of federal poverty guidelines will increase eligibility in states. Now, the question that you should be able to answer is, are all states participating? And the answer to that is no. And ironically, the states that really have so much, the states that aren't doing well as far as the health status of its residents are states that aren't participating. You see that quite commonly if you look at all the states that decided to opt out. Another piece that I think is worth mentioning here is kids under 26 are now covered under their parents' insurance, which is great. And then under more benefits and protections, I think, I did a lot of, my whole dissertation was around cancer and cancer screening, and that's one example of a service that's covered. Patients do not have to share the cost of cancer screening services as long as they're within the guidelines of the United States Preventive Services Task Force recommendations. Insurance, lower costs for the consumers. You all know about exchange subsidies and how, that's been an interesting process to see different states roll out their subsidy insurance programs, and of course healthcare.gov, but I think that's been worked out. And then improved quality and efficiency. We'll talk about this a lot this week. The Accountable Care Organization, medical homes, incentive payments, really, really important. And then infrastructure for workforce, increasing access to care in schools, as well as Medicaid provider incentives, one of the reasons that persons with Medicaid have a difficult time accessing a primary care provider is because the primary care provider doesn't accept Medicaid, or they have quotas on the number of Medicaid patients they will treat or provide care to. And that's because the Medicaid payment is not commensurate with private insurance and Medicare, and there's a lot of paperwork associated with that. And so because of the ACA, more folks with Medicaid will have access to providers because providers will be paid at rates that are commensurate with Medicare and private insurers, which is a great thing. And then, again, I'm just highlighting some of these. There's so much to talk about. We could go on and on with this one slide. But this last category here, public health prevention, all of the different initiatives, community transformation grants, these are millions of dollars that are being earmarked for communities that demonstrate the ability to, or the potential to transform to communities that, you know, that focus on prevention. And then community health needs assessments. This is a big part of my work. Down at the bottom right, hospitals have to conduct community health assessments, and we have to develop implementation strategies around that. So as you see here, the healthcare reform is changing, obviously, the healthcare delivery landscape. You'll see this has been the traditional model here, where payers and insurers have really been driving the market, but now patients are driving the market, and there's so much information now that patients can be overwhelmed. But with the information is available, and patients are becoming much more informed consumers, and that is important, and that makes a lot of sense because we all know that when we're treating a patient, the patient is in the center of care. And so you see how things are being flipped. Makes a lot of sense. So you'll see the current system, or the traditional model, has been driven by volume and cost data. I'm at the very bottom of the left-hand side. And the future delivery system is going to be driven by patient experience and outcomes data. So accountable payment models. So there are different models and different demonstration projects that are being conducted across the country because we still don't know the answers and we're still trying to figure it out. But we do know that we need to improve quality. We need to provide care at the lowest cost. And, you know, we want to see that we are preventing conditions from occurring. So how do we do that? And so there's different models around pay for performance. Pay for performance is really you do well, you get paid for it, right? So enhanced pay for performance are a range of programs designed to create greater connection between payment levels and clinical performance. And these are some examples: the Medicare value-based purchasing program, the Physician Quality Reporting Initiative, hospital readmissions reduction programs, where payment is based on your ability to perform. And performing is really providing the best care at the lowest cost, or efficient care. And then bundled payments are when a network of providers have a lump sum to cover the cost of care, and providers reap the benefits by delivering high quality care at the lowest cost. And it's more episodic. So for example, if someone's being treated for heart failure, or if there's a surgery, heart failure surgery, the provider may be given a lump sum to take care of that patient. And if the provider can demonstrate the ability to take care of the patient, again, efficiently, any savings would go towards the provider's benefit. And then shared savings models, that's when the total cost of the payment model in which providers are paid fee for service but held responsible for the total expense for a given patient population through a comparison benchmark. So this is like a network of providers. That's why it's called shared savings. And I'll go into each one of these now. So you can see here, this has been classified into two areas: performance risk, and utilization risk. And again, bundle payment here, we just talked about this, pay for performance, and shared savings. So you see cost of care, and when we're talking about bundle payment, these initiatives are supporting providing care at a more efficient and at less costs. All right. And then for quality, pay for performance, these initiatives are supporting quality of care. Remember when I talk about, process reliability is when there's a process that if we implement this process consistently, we'll achieve the same outcomes. That's what that's all about. Clinical quality, again, we want to be sure that we're not harming patients, right? And then patient experience is around everything that the patient experiences when he or she is interfacing with the healthcare system. This goes beyond the doctor-patient relationship. It's about, was my room clean? Did people speak to me? Was the food good? Was parking an issue for me? All that's part of the patient experience. And then over here, volume of care, again, shared savings. And so when we're talking about shared savings, we're talking about different partners working together and treating and caring for a patient over time, and reducing costs and tertiary conditions or need for surgery and so forth. And so chronic care management, care substitution, disease prevention are all focused on the volume aspect. This information was pulled from the document that you're reading, the Population Health Leaders Reading List, and it was published in 2013, last year. So there are a few key terms that I want to be sure that we cover. One is the patient-centered medical home, clinical integration, and then the next slide, I believe, is on the accountable care organization. So you've all heard of patient-centered medical homes, I'm assuming, but it's pretty much a primary care provider that's coordinating a continuum of services. It serves as the patient's official medical home. And our goal in this country is for everyone to have a medical home and to understand the premise behind a medical home and how it promotes the continuum of services that are needed from a lifespan, from, again, pediatrics to geriatrics, and all of the issues that may surface or arise within that time period. So the characteristics of a patient-centered medical home: it's an interdisciplinary team. They have a disease registry that they're looking at. So you're looking at a panel. So let's say you have a medical home and you have 500, let's say it's 150 patients with diabetes. The goal is to have a registry and look at those 150 individuals over time to demonstrate that there's an improvement in health status. So your work is guided by looking at reports and, how patients' health has actually changed from when they first joined your medical home, 6 months later, a year later, 5 years later, so that you can tell a story. And you can also use it as opportunities for improving your performance. Patient-centered medical homes understand that the patient needs to be engaged in his or her care. Gone are the days when, just do what the doctor tells you to do. It's really a partnership. Improve patient access. Again, one of the reasons that people use the ER is because they can't access their medical home, or their medical home, hours of operation are limited or so forth. So there needs to be improved patient access. And as I said earlier, there needs to be a continuum of care coordinated through the medical home. So remember, medical home isn't just my doctor anymore. All right, it's a place that provides a continuum. Well, the medical home may not provide all the services, but they have partners and a network to ensure that the patient's needs are met. Clinical integration, fancy term for just saying information technology that's shareable, that is shared amongst the providers who are taking care of a patient population. Characteristics of clinical integration include clinical and performance metrics, a coordinated IT infrastructure. So if you're sending a patient over for some type of diagnostic examination, then there needs to be an IT infrastructure that is coordinated so that the primary care physician has immediate access to the results of that. It shouldn't rely on a patient taking a piece of paper back to his or her doctor with the outcomes, or it shouldn't be a fax. Oh gosh, those days. And then joint contracting, in which providers are contracting with other providers, again, to ensure that the continuum of needs are met for a patient. Accountable care organizations, it's a group of providers, including physicians, hospitals, post-acute organizations, that are collectively responsible for the total cost and quality of care provided to a panel of patients over time. And so there's about 32 pioneer accountable care organizations across the nation, and in just a few minutes I'll share with you the results. We have some preliminary results of their work. But the characteristics of accountable care organizations, again, they must have a coordinated IT infrastructure. They need to have standardized pathways of care, partnerships with payers who are willingly to engage and be incentivized by providing care efficiently so that they can also benefit from the cost savings. And then they're all looking for ways to provide care at the lowest cost. Improve care, but provided at the lowest cost. So where are they? These are, as of August 13th, these are the locations for the accountable care organizations across the nation. The turquoise are pioneer ACOs. The red indicates the shared savings accountable care organizations. There's a 2012 cohort, and then the purple is the 2013 cohort. Now remember, these are Medicare accountable care organizations, and one question I may ask you is, why are we focused on Medicare? And your answer is, that's the only federal program where we can look at Medicare claims data and we can tell a story. Medicaid is a state-based program. There's no other program that's a national program. So we can learn a lot from the Medicare ACOs, but I'm always concerned about, adults or folks under 65. Their issues are different, their needs are different, their health issues are different. So, we're limited. There's a limitation there when we're just looking at the Medicare ACOs, or we're looking at Medicare and trying to develop strategies or pathways and adapt those to those who are under the age of 64. Their reality is a little different, and so we just need to be sensitive to that. All right, so these are the accountable care organizations across the nation. Where are we, and what have we learned for the first year? More than 669,000 individuals were impacted by these 32 accountable care organizations. Overall, the financial results were positive, but inconsistent across them. And you'll see that there's significant savings here, something to celebrate. 87.6 million in savings just in 1 year across 2012. That's major. Wonderful, wonderful thing. And you'll see while the financial results were inconsistent, with roughly 40% of participants qualifying for shared savings bonuses, the quality results were more uniformly positive. And you'll see, look at this one here. 25% 25 of the pioneers demonstrated successful readmission reduction, outperforming the benchmark for all Medicare beneficiaries. So basically the benchmark was, let's look at readmissions for all Medicare beneficiaries before 2012 or 2013, and so that was the benchmark. And so using that benchmark, those participating accountable care organizations were able to demonstrate a reduction in readmission rates that outperformed prior benchmarks. Okay, So the takeaway for this piece is, although the ACA passed in 2010, there's still a lot we don't know. We're still trying to find our way, and that's what these demonstration projects have been about. That's what the Accountable Care, the pioneer organizations, are demonstration projects. Demonstration projects are funded typically by the federal government, and the whole purpose is, let's test something that we think has some efficacy and see what the outcomes are. If the outcomes are desirable, we take it to scale. And so those accountable care organizations were volunteers. No one made them do this. It was a volunteer effort because, of course, their interests are consistent with national interests. Well, all of our interests are the same, but some communities and some systems were just much better positioned to take on the accountable care organization concept. So we still don't know. How do we organize services? How do we engage patients in a meaningful way? How do we reform health practitioner training? How do we incorporate technology, right, in engaging patients in a meaningful way? How do we incorporate the social factors in the standard of care? That's what, my friends, that's what strategic thinking is all about. And when we have strategic thinking, we will get closer and closer to the answers to these very, very challenging questions. Okay, that's it for this lecture, and I hope that you are having a great week, and I will see you next week.